I'm going to have to go ahead and get going right now. That way we don't run too over. So if you're going to get coffee, I love coffee. I missed a little bit of my coffee today, so go get your coffee. You'll be better off for it. You'll enjoy the talk more. I'm Dr. Glenn Kader. I'm a colleague of Dr. Callaghan at the NeuroMedical Center, and I really love the DBS portion of that talk. That is one of the main reasons why I chose to come to Baton Rouge. That program was already started by Gerald, and it was in place with Dr. Wagaspak in-house, and it's a great opportunity for the people of Baton Rouge who have problems that need deep brain stimulation, like essential tremor and Parkinson's disease, to where they don't have to go to a big center like in Houston or in Birmingham, and they can get a really fantastic job done here. So let's talk about what I'm going to talk about today. Actually, just to give you a little bit of background, I'm an LSU grad. I'm from Natchez. I went to medical school in Jackson, and I trained in Houston at the University of Texas at Houston. So I've been here 2 years. I really enjoyed my time here so far, and looking forward to spending the remaining time of my career here. So today I'm going to talk about the non-motor symptoms of Parkinson's disease. And you know, if you looked when Dr. Standard was going over the pamphlet of Dr. Parkinson's, who is a surgeon, by the way, he wasn't a neurologist, and he mentioned something at the bottom with the senses and intellect intact. And, you know, that's not really true. He was a great man, did a great thing, and, you know, I am never going to have a disease named after me. A, I think there's enough diseases going around. I don't want any more. B, you know, you just have to really appreciate all that he did to have this problem become recognized. But at the same time, it wasn't complete. You know, it's very interesting, and Dr. Standard brought it up. He described 8 to 10 people. Only 4 of those were his patients. He saw them walking down the street, which is pretty interesting, you know. We like to observe people as well, but we certainly can't get a whole disease process described by just looking at 10 people. So the non-motor symptoms. Let me tell you how I feel about them. Let me get to that next slide. Just bear with me.
Yeah, Mo, that team sure did suck last night. Yeah, Mo, that team sure did suck last night. They just plain sucked. I've seen teams suck before, but they were the suckiest bunch of sucks that ever sucked.
Homer, what's your...
And so that's what I think the non-motor symptoms of Parkinson's disease makes this disease. It's very difficult to deal with because, you know, a little shaking's one thing, a little, you know, not being able to move, it's certainly very limiting. And as the disease progresses, it's very difficult and trying. But, you know, if you took a sample of Parkinson's patients, which, hey, we have a good sample here today, a lot of the problems that arise are from the non-motor symptoms that are really debilitating to the patient and to the caregivers. In the earlier slides today with the picture of the haggard spouse, you know, that's not from the shaking. That's from the non-motor aspects of Parkinson's disease. So let me get out of this. All right. And I have to thank my wife for helping me get the videos on. I'm really good at video games, but not at PowerPoint, so she did a really good job helping me get these links. So the premotor symptoms of Parkinson's disease, Dr. Standard was going over, he had a slide similar to this of what people feel before they actually have the motor symptoms of Parkinson's disease, the 4 cardinal features that he talked about. The rigidity, the tremor, etc. And he talked about the loss of neurons. You know, it's thought that the motor diagnosis of Parkinson's disease, the loss is already at 60 to 80%. So that's a pretty significant loss of function before you get to that point. And these other premotor symptoms are precursors of the following motor degradation because of the neurodegeneration. And that's a term that we use a lot, and that's just basically unfortunately, a continuous loss of neurons. Hopefully it's slow, and certain disease processes in the Parkinsonian world advance a little bit quicker, like the atypicals, but it's steady regardless. Thank you. The coffee is critical, and y'all please make sure you have some. So, decreased olfactory function. Lack of sense of smell or a loss of sense of smell. It is a very useful tool in identifying people who are at risk for Parkinson's disease, although it's not very practical. You can't just give people a big smell test, say, hey, take this home. If you fail, you might have Parkinson's. That's not very practical. But in a population, say, family members of a patient who are worried that they may have some link to it, it's pretty useful, because decreased sense of smell is a cardinal feature of Parkinson's disease, and up to 80%, usually before they have motor symptoms, will have a loss of sense of smell. The Pennsylvania smell test is a very good smell test that we use in Houston to help identify people. It's also very useful in helping to differentiate between the types of Parkinsonisms that are out there. We mentioned earlier on in the lecture series that it's quite difficult in the early stages to tell the difference between Parkinson's and one of the Parkinson plus syndromes, because the plus just haven't had time to develop yet. You just have the motor stages fairly early on. So for Parkinson's disease, you have a much higher prevalence of decreased sense of smell than something like multisystem atrophy, and it helps in early prognosis and treatment. It's really basically a scratch and sniff. If you've done those with your grandchildren or kids, it's basically a fancy scratch and sniff. But the impairment's profound in some people, in the sense that they can't, if early or Parkinson's patients who we give this to, they can't smell motor oil, which is pretty distinctive and strong, so that's a pretty big loss. And they'll say, hey, I haven't smelled well for years, for 10 years, whatever. Or I've never could smell really well, and that's just kind of part of it. Sleep dysfunction. And so if I'm going fast, y'all just bear with me. We're trying to get y'all out of here at a good, decent time, so you're going to have to forgive me. So sleep dysfunction. It is thought to be one of the earlier predictors of Parkinson's disease, particularly REM behavior sleep disorder. This is a fascinating disorder because everybody dreams. We all dream. We all remember some of our dreams. Some of them we don't. But whenever you dream, a couple of things remain not paralyzed. Your ability to breathe, obviously, that would be inconvenient. Your eyes, your eye movements are preserved. And, if you've seen videos of people dreaming, or if you've happened to just stare at your loved one while you're next to them, I'd kind of be worried about you, but you can see their eyes moving back and forth, and so they're in the REM sleep, which is rapid eye movement. So if you have REM behavior sleep disorder, it's an uncoupling of the other muscles of your body during dreaming. So I have a video for that, and it's pretty impressive. The latter part, the first part's just kind of creepy because it's just not a good video, and somebody's sleeping and snoring really loud, but if you notice, even early on, before you have the really major part of this video, he's still moving around and acting different than one would expect. All right. A little help. Thank you. Sure. You have to know your limitations. I've learned that in life, and this is one of mine. Maybe we have to X out and go back in or something. That's what we had to do earlier. There you go. Strong words. it's all funny and good unless you're sleeping next to them. You know, then it's not so funny. Yeah, you know, I had some problems earlier on when I didn't exit out at home, so I'm going to have to exit out. All right, thanks. So it's a pretty dramatic video, and, you know, it's something that could certainly interrupt not the patient's life, really, because, you know, he's sleeping, but the loved one's life for sure. So, you know, it's really interesting in looking at the data on REM behavior sleep disorder. So when you look at certain subsets of pretty big populations for study, like 60 to 80 people in REM behavior sleep disorder studies, about 60% of them over 5 years who actually had the disease went on to develop some form of Parkinsonism, either regular old idiopathic Parkinson's disease or multisystem atrophy. And then when you look at another subset of people with multisystem atrophy, a majority of people did have REM behavior sleep disorder. So it's pretty interesting, the link there. Excessive daytime sleepiness. Dr. Callaghan touched on it earlier in that, you know, if you're driving and you fall asleep, it's pretty bad, obviously. But, you know, it can affect people in two different ways. Number one, it's just part of the disease to some degree on certain people. And you know, Parkinson's, as it's been mentioned before in some form or fashion, it's not one disease. And the symptoms vary from person to person. So the sleepiness during the daytime, not everybody gets it. Not everybody gets it to a dramatic degree. But at the same time, it can certainly affect people's lives. And the medication that we give to treat Parkinson's disease can exacerbate that problem. So if you're on carbidopa-levodopa, and you have Parkinson's disease, which you should be on that drug unless you just can't tolerate it, it may make that sleepiness worse. If you're on dopamine agonist, in the combination, it could certainly make those symptoms much worse. So we just have to monitor that and to do the best we can, and not to focus on the treatments too much, but you know, we do have to focus on the positive, because a lot of these things we can make better to some degree. So there is hope. It's not just all doom and gloom. Everybody's going to have all these symptoms and there's nothing we could do. But we just have to work within the limitations sometimes of the medication. And psychiatric, depression and anxiety. And all this, remember, is before Parkinson's is diagnosed, the premotor, because, you know, it's really not picked up unless you have the cardinal motor symptoms, because it's a clinical diagnosis and you have to have those to get diagnosed. So depression and anxiety is very common comorbidities with Parkinson's disease, and it's not just because you have Parkinson's disease and you're dealing with this life-altering process, and I'll go into details about depression in a little while, the different areas of the brain, but you know, 30% of people before presentation have depression. 30% have anxiety, and those are around, it could be 32.3%, you know, that's depending on the studies, but, you know, a fair number of people have it before they're even diagnosed. So, and that's from a loss of neurons before the physical symptoms come into play. Constipation. You know, you don't think of a primary brain disease as giving constipation. You know, it's not usually the direct link there between the brain and the gut. But I do got to say, in about 80% of the Parkinsonian population, they will eventually develop constipation, or at least slow motility of the gut. So it affects the mesenteric plexus in the gut, and it certainly makes a big difference that you have to treat with medications. Sleep. So we already mentioned the excessive daytime sleepiness. And we have some extended release medications out there right now, such as the extended dopamine agonists, which do help that, because if you're sleepy, the max onset of sleepiness with those medications is roughly 6 hours. So if you take them before you go to bed and you get sleepy while you're sleeping, that's great. You know, you're asleep. But, you know, it still can be a problem for some people. And another problem is the sleep cycle itself is disrupted because of loss of neurons, you know, and it just really affects it, and you don't get the quality sleep that one did before Parkinson's developed. Discomfort. So you have a not well studied or well proven link between restless leg syndrome and Parkinson's disease, but it seems like a lot of people with Parkinson's disease have similar complaints. That's because some of the non-motor symptoms of Parkinson's are very similar to the feelings that people get with restless leg disease or restless leg syndrome. It's often wearing off of the medications during night. You'll feel uncomfortable. Some dystonias are similar to those symptoms. And vivid dreaming. Vivid dreaming, it's quite prominent as the disease progresses, and people will often, if you ask them about it, they'll tell you that they have some really wild dreams, especially if they're on dopamine, and it just makes them very memorable, sometimes disturbing, and it could certainly affect their sleep if they wake up from a vivid dream and they just don't want to go back to sleep because it's scary. So that is something that you have to be aware of, and really no good treatment for that. It's just something that's there. Okay. These are some fancy words up here. Mesocorticolimbic, dopaminergic, locus coeruleus. I really put them up here just to feel good about myself. But let me show you these pathways. And look at the VTA, the ventral tegmental area, is the primary dopaminergic pathways that alter mood. Noradrenergic and serotonin. That you've heard of SSRIs, and we mentioned them. They modulate the serotonin available in the brain. And so let's look at these pathways. Wikipedia, good stuff. You'd think you'd find something in our journals and everything, and I'm sure they're out there. It's just Wikipedia is so much more user-friendly. Okay. This was very similar to something that Dr. Standard had earlier. And these are just different areas of the brain. And you have the different colored pathways. Dopamine is in blue, serotonin is in red. And they have the different areas of involvement in mood. So dopamine is heavily involved in reward, pleasure, compulsion in the brain, and you have different disorders of dopamine. One, you don't have it, such as Parkinson's. One, that's thought you have too much, and schizophrenia. And the modulation of that dopamine area is very important in behavior and even addiction. So it plays a crucial role in mood. And so as you lose those neurons, it certainly has an effect on mood and behavior. And that's why it's such a prominent feature in Parkinson's disease, even before the motor symptoms are there. It's not just neurodegeneration, however, in the dopamine neurons. It's in other areas of the brain, including the serotonin pathways and the noradrenergic pathways, that certainly play a role in the prominence of depression in a Parkinsonian patient. Anxiety is very similar. It's just not as well studied, and I didn't find as good of a picture, so I'm not going to talk about it. But not to just brush over it, because anxiety is a really key component, just as much as depression, that people have to deal with on a day-to-day basis. And the medications that we use are very similar, SSRIs, or some of the newer antidepressants that hit multiple drug pathways, so multiple receptor pathways, not just serotonin. Examples of that are Pristiq and different other types of newer drugs. Neuropsychiatric, dysexecutive syndrome, visuospatial, dementia, and psychosis. That's just the types of problems you could have that progress as the disease progresses. Obviously, psychosis and dementia are endpoints, and it's unfortunate that the Parkinsonian patient is at such high risk to develop dementia versus the average age-matched population. So it's roughly a 4-time greater prevalence in the Parkinsonian population, and that really takes a toll on the support system of the patient, the family, loved ones, etc. Psychosis, it is obviously difficult to deal with. There's only a couple of medications out there that work pretty well in a Parkinsonian group. For example, Seroquel and clozapine, exactly what Dr. Lee mentioned earlier. And you have to, the other antipsychotics certainly can help with some of the psychotic features, but you have a lot more motor complications. So it'll make the Parkinsonian features worse, and it's hard to find that balance at times. Dysexecutive. So it was a good, really, I'm glad we had the talk a few minutes ago talking about the multitasking, the high-level function that becomes more difficult if you don't have proper dopaminergic function in the brain. And it's great that you heard that stimulation, deep brain stimulation, has helped, just on a personal basis. He gave testament to that. Autonomic dysfunction. So multisystem atrophy, Lewy body disease, and dementia, they are certainly not Parkinson's disease. The top two are a Parkinsonian plus or a Parkinsonian-like disease process. It's really interesting, orthostasis. I'm not going to name names, but I have a patient in here that I just talked to today about how they were doing with that very problem. It's certainly troublesome when you get dizzy just by standing up. And the crucial factor in multisystem atrophy versus Parkinson's disease is the time of onset. So in a patient who has multisystem atrophy, it's roughly 24 months. So by the time they first have any sort of problem to when they get orthostatic symptoms, 24 months versus 144 months in a Parkinson's disease patient. So that's a great deal of difference in onset of the problem. So how do you treat it? You treat it with flurgicortisone, midodrine, and I've never used that other drug, so I can't really speak to that. Have you? No. Yeah, so it was, I'm sure somebody has, but I haven't, because the first two usually work to some degree. You just have to make sure that you work with a primary care physician on that, because they're managing the other medications that are often used to treat other medical problems, which can be affected by both of those medications. So mechanical therapies, behavioral therapies, and diet, those are easy, simple things that can be done, such as pressure hose, eating a little bit more salt. That could certainly increase the blood pressure a little bit. And basically what happens in this whole process, it's a loss of autonomic regulation. So autonomic dysfunction, it's not just to orthostatic symptoms, it's to sexual dysfunction, bowel and bladder dysfunction. I'm just checking the time. I'm way over. But it's a lack of communication in what the body usually does on its own without you thinking about it. It's lost because neurons are just not there anymore. They've degenerated away. So it's very rare in a clinical setting to walk into a patient's room and say, "Hey, how's your sex life? It's going well?" No, that's not usually what happens. And it's very rare that people will give that information out. But sexual dysfunction certainly does happen in Parkinson's disease from this autonomic dysfunction that I was talking about. In fact, that was one of the questions that was brought up earlier. Talk about sexual dysfunction, talk about difficulty with interest, and those are two sides of the same coin, the physical and the mental, and that's what we're kind of addressing here. There's multiple areas of the brain that are affected that lead to problems, not just in movement. So, and this is one of them, and it's much easier to treat the man, because they have pretty good medications out there. You see them on TV all the time. Watch a football game. Seriously, it's coming up. You'll see 10 commercials at least for the medications that are out there, and they're pretty effective. So just you need to make sure you mention it to your doctor, because oftentimes when you're talking about the course of the symptoms, it won't come up, which is understandable, but it's a big part of life. And I was going to have a video of like Salt and Pepper song on there. I don't know if y'all know who they are, but I decided against it. But it was I was tempted. So bladder dysfunction. So bladder dysfunction is quite common, and we have a really good urologist in town that does deal with neurogenic bladder quite often, or bladder dysfunction seen in neurological processes. So if you could just talk to us, we could certainly refer you in the right way, because you need bladder studies if you're having significant problems, because there are different medications out there for particular dysfunctions. All right, pain. So let's talk about pain. He says it better.
What's your prediction for the fight, then?
Prediction?
Yes, prediction.
Pain.
You gotta love Clubber. That didn't come out as well, but it's really good in the movie. Anyway, so sensory symptoms. I think today we've experienced some of the sensory problems in Parkinson's disease. Not half, that's an exaggeration, but a good deal of people came up to staff today saying that it was cold. A good deal of people came up saying it was hot. And, it was somewhere in the middle, but, people with Parkinson's disease experience the sensations somewhat differently. Some people get sensitivity to cold, some people get sensitivity to heat, and that is part of the sensory symptoms that you can have that are non-motor and certainly affect you. Tingling is another problem that we'll get. I just saw a patient the other day talking about numbness and tingling. It could be carpal tunnel syndrome, but I don't really think it is. I think it's because of her Parkinson's disease, because she's getting some in the feet as well. And, we'll test her, make sure there's not a big neuropathy there. But at the same time, it's probably from Parkinson's. Pain. About 40 to 50% of patients do have pain that can't be explained, even with all the MRIs that we could do, all the nerve conduction studies we could do. We just can't isolate a problem. And you certainly shouldn't neglect the other physical things that could cause pain, because, as y'all know, you could certainly have other medical problems besides Parkinson's disease, including back problems, including carpal tunnel syndrome, whatever, but a quite large amount of the population certainly is affected by that. Burning and coldness, it just happens, unfortunately, more sensitive to one or the other. And I kind of sped through those last couple because we're running late, so we're good. All right. Thank y'all.